All right, thanks very much, Mike. And again, this meeting has characteristically had a lot of government employees from the FDA, from NIH, but it really is wonderful to see that with a virtual course, we've been able to expand our audience, and I think that makes a much more vital course. So what we're going to start with, usually I start with focusing on opportunistic infections, but I'm going to broaden that a little bit this time, but start out with what's happening in the city where this, for 27 of the 28 years, occurred, Washington, D.C. I don't have any relevant financial issues. The learning objectives are to focus on the data from D.C., to list newly described issues. I'm going to focus on health disparities and comorbidities, and to talk about some issues related to opportunistic infections. For many years, we've in Washington had really a lot of cooperative efforts focusing on the HIV problem that we have. And just to remind you, we were late in the game of getting organized for HIV. It wasn't until 2007, when a new administration came in to the city, that we actually looked at the data about HIV. And I think it probably was not a surprise, but it was important to document that Washington had the highest rate of HIV of any place of any metropolitan area in the country. So that NIH, the universities, the District of Columbia Department of Health, which had new leadership, got together with the GW School of Public Health, and over the last 12 years have really worked together in a cohesive, cooperative way that had not existed before 2007. So one of the questions I would ask you, and this might be mostly for people who live in D.C., is how many new cases of HIV do you think were reported in 2019? And the mayor issued a report relatively recently that summarized 2019. But what order of magnitude do you think this is? So why don't you start polling and just think, how far have we come? And I'll give you a little hint that in 2007, we had 1,300 cases in that year. Okay, so there's a range of people, and actually 42% got what is the right answer. So if you look at the data, what this graph shows is the blue bars are the number of people living with HIV, which has gone up to 18,000 because people are obviously both acquiring HIV and living longer. The green line shows the number of deaths, but what I'd really like to focus on is the red line, which is the number of new cases. And in 2007, when we started working cooperatively, there were about 1,300 new cases. And I think we've been very pleased that over the last 10 years, we've gone from 1,300 to last year. There were about 275 new cases in the district. And we have looked at the rate of decline in the 50 CDC-defined hotspots in the United States. And D.C. has had the largest decline of any area in the country. And again, I think this reflects a lot of cooperative effort in a city that had a huge problem and still has a problem, but much less. The mayor of D.C. has goals which mirror what CDC has. And if you look over on the right, that shows what her goals were in terms of where we should be in 2020. And I think what I want to show you here is that these were very ambitious goals in 2015, but I think that we're very close to being able to get to those targets in 2020. We will, in fact, not know the 2020 data until sometime in the second quarter of 2021. But you can see in terms of having most patients know their HIV positive results, in terms of having patients who are suppressed on treatment, and seeing the number of new cases in terms of targets, I think we're very close to those goals. And I think if you had looked in 2015 and said, do we think we're going to get to those goals, I think many of us would have been pessimistic. But again, I think this is really dramatic and reflects a lot of effort in the city, as well as help from CDC and other federal agencies. It's important to recognize that in DC, 1 in 4 of our newly diagnosed patients are Black women. 2 in 5 are non-Caucasian males who have sex with males. There are a lot of younger people, and there are many who can be identified because they've had at least one sexually transmitted infection in the last 12 months. So these are the patients these are the individuals we have to focus on, the patient populations. I think there are more projects now trying to focus on who are the new cases, who is out of care, particularly people who have substance use disorder, people who are homeless, people without insurance, and to try to get access to them so that we can get that number from 275 new cases to the aspirational goal of 0, and try to get the people who know they have HIV to be durably suppressed. So I think we're making progress, but we still have some populations that we know that we have to target. So from ID Week, I'd like to tell you about a couple of presentations that I thought were notable on health disparities and on the aging population. I was going to talk about PrEP, but Monica Gandhi is going to do that. And I'll talk to a little bit about opportunistic infections because I never let an opportunity go by without talking about them. One of the talks at ID Week that I thought was particularly powerful was by Ada Adamora, who's talked at IAS-USA many times before. And her CAST lecture was entitled, All Policy is Health Policy, A Pathway to HIV and COVID-19. She went back to recall her experiences in the 1980s when she was a fellow at Einstein. And like everybody else, she recognized that the number of sexual partners that patients had was a risk factor for HIV transmission. But her personal observation was that in minority populations, high-risk behavior was not invariably a factor. There are patients who did not have high-risk behavior who still got HIV, and that very early on, it was very clear to her that poverty and race appeared to be risk factors for HIV, but that began a career in which she tried to establish data on how often were poverty and race issues and why did this happen. She focused on a number of different things, but one was something I think we see in the news a lot, mass incarceration. And I think we all recognize that there are way too many people incarcerated, that there's been a huge increase since the 1980s, and that the lifetime risk of incarceration is much greater in non-Caucasian populations, as you see here among Latinos and Blacks. She made a number of observations. One is with all of these Black males being incarcerated for periods of time, this leads to unstable families, unstable finances, and with sexual partners being unavailable and in prison, this leads to concurrency by both those in prison and out, and that leads to obviously potential for HIV transmission. She also focused on the fact that having people incarcerated, whether they're in jails or prisons, often due to the nature of our healthcare system, leads to transitions that exacerbate gaps in care where their regimens outside of prison are not continued in prison and vice versa. And this leads to more HIV positive individuals being able to transmit than that should happen. And she made, I think, the very good point that we see data about people who have been incarcerated for felonies not being able to vote or not being able to vote unless they pay various fines that they have. And she made, I think, the very compelling point that if these people were able to vote, that the results of some elections like Gore versus Bush would have been changed if they were able to vote and if they voted, because there's such a substantial number that they could change government policy with their votes if we allowed them to vote, but in many areas of the country, we don't. She also made a point, which I'm sure is obvious to all of us, that the federal government has plans to end the U.S. HIV epidemic. They focus on things that are well known to us on diagnosis, treatment, and prevention. But the problem is, if you don't have health insurance, Yes, there are services in Ryan White clinics and so on, but it makes it much more difficult to get access to those services. There's states that we all recognize that have not adopted Medicaid expansion. They're shown here in yellow. And she makes the point that, again, policy related to criminal justice, policy related to budget, all ultimately affects healthcare policy. And again, this gets back to a major theme that all policy is health policy. She drew some parallels to COVID-19. And again, I think these are issues that are well known to the group here, that Black people are dying of COVID-19 at twice the rate of white people. There's some data shown here about deaths per 100,000. And she made the interesting points that the issue isn't so much that once they get into the hospital, they're more likely to die. The problem is that because of comorbidities, because of lack of access to care, they're hospitalized much more often. And although, again, their trajectory is no different once they get into the hospital, a higher proportion are hospitalized, and thus a higher proportion wind up dying. And this is particularly notable in states that do not have Medicaid expansion. So again, I think this was a very powerful talk, and one that if you have access to ID Week is worth listening to. So the bottom line was that racial inequities of HIV and COVID-19 are not inevitable. They're a result of social, economic, and political forces that we can do something about. The changes are not just in healthcare policy, but they're in the criminal justice system and in healthcare insurance as well. And that while this isn't going to reverse the changes, the effects of centuries of racial injustice, they will improve the lives of many people who are currently here. Another talk that I thought was interesting was by Carrie Althoff of Johns Hopkins and of NA Accord, and that was a focus on the aging of an epidemic, which I think all care providers recognize. She focused on three main issues that influence aging. And again, I don't think any of these are a surprise to us, but I think it was an interesting way to look at it. One limb was the effect of HIV and viremia and inflammation and immune activation on causing accelerated end organ damage and morbidity. A second arm was the effect of drugs, the older drugs that we don't use anymore, the D drugs, but which some patients are still suffering from the effects of, as well as newer drugs like the integrase inhibitors that affect body mass. And then the issues which are overrepresented in HIV, smoking, stress, diet, food instability, lack of exercise, and the neighborhood you live in terms of your access to health care or healthy food. She pointed out data from Kaiser Permanente that there are really two issues we should look at. One is overall survival. I think we recognize that if you look at overall survival, patients with HIV are catching up to non-infected patients. So you can see the y-axis here looks at the time remaining for 21-year-olds, how long they're expected to live, and you can see there's a 6 or 7 year difference. But what she wanted to focus on was really your years of healthy living, your years where you were free of major comorbidities, and you can see that that is a much smaller number than simply being alive, and that there's a larger gap between HIV and non-HIV. So her focus was what she called the health span disparity, and that is that we really need to focus more on all the issues which cause aging, and that are the comorbidities, that our goal should be to delay the onset of aging by focusing on not just HIV, but on smoking, on lack of exercise, on diet, etc., and that we really would like to get to focus on how they can have a healthier life without comorbidity before death. So again, focusing on wellness as well as mortality. So I think, again, that was an interesting concept that's worth looking at. There's also an interesting presentation on HIV reservoir. And I have to say, I was not initially going to talk about the HIV reservoir, but when Raj Gandhi heard that his sister was getting a major opportunity to present her data here, he called me and said that the coming from the East Coast, he should get equal time, so I should present some of his data. So it's largely because of that I'm presenting this. But this was a presentation that was very interesting on the selective decay of intact HIV proviral DNA by antiretroviral therapy. And the issue here was whether antiretroviral therapy really has an effect on the viral reservoir. This is obviously relevant to cure. They looked at a convenience sample of 50 patients, and you can see that some of the patients they had data on at time point 1, some at time point 2, some at time point 3. So this was not really necessarily a comprehensive look at a predetermined group, but I think it nevertheless provides interesting data. And while there was a lot of issue about intact and defective proviruses, if you looked at intact proviruses, which is a one indicator of viral reservoir, you can see that over the 3 time points, the viral reservoir appeared to go down. So this was good news that antiretroviral therapy does in fact appear to reduce the viral reservoir, and this ultimately has implications for HIV cure. So again, I think this was interesting science that was done at ID Week. So at ID Week, I was looking for other material on opportunistic infections, and I have to say there was not a lot to present. At this meeting in the past, I've talked about beta-D-glucan, and there are some speakers at IAS-USA that are more enthusiastic about the use of beta-D-glucan, particularly for the diagnosis of pneumocystis, than I am. There are 2 interesting presentations that I'm not going to show you the data on, showing that beta-D-glucans are elevated as frequently in histoplasmosis as in pneumocystis. So if you're practicing an area with histo, this is a particular overlap with beta-glucans, and obviously beta-glucans are up with a variety of yeasts and molds. And there's also another interesting presentation from Arkansas showing the high morbidity of disseminated histoplasma, part of which is due to the fact that it's often not diagnosed promptly. So again, the bottom line to me was that beta-glucans can sometimes give a hint that patients have pulmonary disease due to fungus, but it doesn't really tell you which one. And there are many other causes of false positives, false negatives. So I've never been enthusiastic about using beta-D-glucan as a pulmonary diagnostic. I think there were at least 2 poster presentations supporting that. There are quite a few presentations on co-infection of HIV and COVID-19. And again, without going into the data, I think it probably is obvious to everybody in this room that if you have a patient with HIV in this era, you have to wonder whether their pulmonary infiltration or their fever or their GI illness might be due to COVID-19 and make sure they're screened. And conversely, patients with COVID-19 may have HIV, and there were cases presented, a patient with COVID-19 who had unrecognized HIV who presented with pneumocystis that at first was mistaken for COVID-19, but they actually had 2 processes going on. So again, I think this is something which infectious disease people are always cognizant of having more than one problem. And again, just a very concrete reminder of that. There are other interesting issues at other meetings and other venues, and TB and cryptococcal meningitis are 2 that are worth talking about. Let me ask you another question, and the question relates to the treatment of latent TB, and the question is as follows. Which of the following is a preferred regimen for prevention of latent TB in people living with HIV who are either IGRA or PPD positive and have presumably not been previously treated? And again, we'll ignore drug-drug interactions or what antiretroviral regimen they're on at the moment. So why don't you look at these 4 options and vote? And when Mike Sag is doing this, he's going to tell you what the music is. I'm not going to tell you. Well, that's interesting that everybody has a little different view. And one thing I think people have to realize is that in my era, people of my vintage, isoniazid for 6 to 9 months was always the preferred regimen for TB prophylaxis, and now it is not the preferred regimen whether you're HIV positive or HIV negative. So there are 2 points I want to make here. One is, what are the preferred regimens? And then there's a lot of discussion about a 1-month regimen. Do we use that? And if not, why not? And just to remind you, in terms of people living with HIV, there are 2 preferred choices. One is the so-called 3HR, which is isoniazid and rifampin. So that is daily regimen or 90 doses of drug, and that's a 3-month regimen. There is another 3-month regimen, which is only 12 doses because it is weekly isoniazid, not with rifampin, but with rifapentine. So that is a recommended regimen, except it's only recommended if you're on efavirenz, raltegravir, or dolutegravir, simply because there isn't good data and there are drug interaction issues with other regimens. The rifampin daily regimen, which I'm not sure is used very often, is a recommended regimen if you're HIV negative, but is not a recommended regimen if you're HIV positive. So the non-recommended, or I should not say non-recommended, the alternative regimens, and I think when you see the OI guidelines, this is something which is being debated right now. But in the past, isoniazid daily was not recommended simply because compliance is much lower with this than the 3-month regimens that I mentioned. The rifampin daily regimen is recommended if you're HIV negative, but is not recommended if you're HIV positive because of drug interactions, among other things. So the question is, what's wrong with this 4-week regimen of isoniazid and rifapentine? There's been a trial, which most of you have probably heard about, the BRIEF trial, which was an ACTG trial, in which they compared daily isoniazid for 9 months. And again, you could argue between 6 and 9 months, but this was isoniazid for 9 months versus the 1 HP regimen, which is daily rifapentine and isoniazid for a month. So it has the advantage of being a very short regimen. This was a trial that was done in all HIV patients. They had a relatively high CD4 count, but this was not done in the United States. Only 50% of the patients were on antiretroviral therapy. This was done in high endemic TB areas. But it's interesting that because of the nature of the study, while it was a high endemic area, only 21% of the patients had a PPD that was recorded as being positive. Either they were negative or it wasn't done. So that while they lived in an endemic area, it wasn't clear that all of them had latent disease. And we'll get into what the implication of that is later. And there are a variety of endpoints looked at that included confirmed and probable TB, death due to TB, but also included deaths of unknown cause. And in this study, 3HP was in fact non-inferior. It had higher completion rate. So in many ways, it was a very attractive regimen. But I think one of the things that has caused some experts not to use it with HIV is that in this study, the number of patients at risk was low. We only know that 21% had a positive PPD. Even though it was in a high endemic area, the number of cases of TB was low, and the relevance in the United States was different, and only 50% of the patients were on antiretroviral therapy, and this was mostly efavirenz and nevirapine. So at the moment, I think the guidelines are still wrestling with this, but this is likely to remain not a preferred option, but an alternative regimen because of these issues with the way the study was conducted. And it is notable that if one is going to use it, it's really only been studied within a efavirenz-based regimen, which is not obviously used here. There is a dolutegravir study, which is in progress. So you're likely to see more data on this regimen later. But right now, the message simply is this is still not in the guidelines. And while we wait to see what the next version of the guidelines shows, it is likely to remain not a recommended but an alternative regimen if you're on efavirenz. In terms of treatment of TB, Sue Swindell, who's going to be on one of our panels, presented at a different meeting, Union of TB, this dose, which is looking for short-term regimens for the treatment of TB, not for prophylaxis, but for treatment of TB. And this was looking at combinations of high-dose rifapentine and moxifloxacin. This was a study that was done in the United States and at multiple sites abroad. And again, doing this kind of study is an enormous amount of work, and I think Sue and her team deserve a lot of credit for getting this done. And without going into all of the detail, if you look at the control group, which is going to 26 weeks, the question is, could you shorten the course? And one short course substituted rifapentine for rifampin, and the question is, could you stop this at 4 months? The other arm substituted rifapentine for rifampin, but also added moxifloxacin. And the bottom line of this study was that simply switching to rifapentine and then stopping at 2 months, stopping at 4 months, was not a satisfactory way of doing it. But if you added moxifloxacin, you could have a shorter regimen. So at this point, there are a number of different regimens, and I think unless you do a lot of TB, you need to look them up. But I think the implications of this study is that it's encouraging that there are shorter course regimens, that moxifloxacin and rifapentine are powerful drugs that we should be using. And again, what was different about this is not only they use a shorter regimen, they also used a higher dose of rifapentine instead of using 600 or 1,200 milligrams a week of rifapentine. This was daily rifapentine. I think we need more experience with rifapentine. We need to be cognizant of the drug interactions, particularly, as I mentioned before, we have more and more older patients who are on polypharmacy. But I think this is good news that the duration of both prophylactic and therapeutic regimens for TB is coming down. The last thing I want to mention are issues about cryptococcal meningitis. And there really have not been changes in our management of cryptococcal meningitis for a long period of time. For years, the recommendations have been what's shown here, to use 2 weeks of liposomal amphotericin and flucytosine, to follow this with 8 weeks of fluconazole, 400 milligrams, and then a longer course of 200 milligrams of fluconazole. And one of the issues has been, are there complications that could be avoided with this regimen? If you used a higher dose of fluconazole, could you avoid some of the treatment failures and some of the ARS that's being seen? Now, one of the problems with opportunistic infection management in 2020 is that there's almost no research being done in the United States. Most of the studies are being done outside the United States. And the question is always, how relevant are they? And there are debates as to how much treatment failure we're seeing in the United States with this regimen of fluconazole 400, and whether there is really a problem that needs to be solved. It clearly is a problem overseas, and the question is, would we benefit from raising the dose of fluconazole in the consolidation range from 400 to 800? The argument goes as follows. If you look at the studies that go back to what Charlie Vanderhorst did in the 1990s, and you look at what are predictors of bad outcome, a positive CSF culture at 2 weeks is a predictor of bad outcome. So you'd like to avoid having a positive culture at 2 weeks, which we try to do by adding 5-FT to amphotericin. And if they're going to be positive, they either need a longer course of amphotericin and flucytosine, or they need an effective, hopefully fungicidal drug. And often you don't know the results of the culture for a week because it'll take a number of days or a week for Cryptococcus to grow out. Now, the problem with fluconazole is that a dose of 400 milligrams is not fungicidal. At 800 milligrams, it probably is fungicidal in at least some people. A higher dose is well tolerated, and there is data from Africa suggesting that if you use 800 milligrams, your outcome is better for those who have a positive culture at their 2-week LP, and there's less IRIS. So based on this, there has been a hotly contested debate as to whether in the United States, where there isn't much data on poor outcomes with 400 milligrams, whether we should take this well-tolerated drug, look at the data from Africa, and raise the consolidation from 400 to 800. I think we'll have to wait and see what the guidelines do, because I think there's been a lot of debate from David Boulware and others about the relevance of this data to the United States, but I think it's something to at least keep in mind. So should we increase the consolidation from 400 to 800? Again, the recommendations may change. We'll have to see. So with that, I've given you a quick tour of DC, a quick tour of ID Week, and a few comments about other things that are relevant. I'd be happy for Mike Sag to pepper me with questions.
Great. Thank you so much, Henry. That was a really nice overview and a lot of important updates and new things. So we got a lot of questions. Let's just dig right in. So first question is about how much neighborhood level geocoding data does the DC Department of Health have on persons with new diagnosis, and is that changing?
They do have data. I mean, they're very focused on exactly where the data comes from. Whether that's changing, I actually don't. I'm not aware of the granularity of that data. But if you look at where the cases come from, the DC report they published, the zip codes and the communities where that's coming from appear not to be very different from what they were 10 years ago.
Okay. There was a little bit of confusion about the 3-HP or the INH with rifampicin or 1-HP. Some of the bullet points might have been a little conflicting, at least as it came across. So the next question sort of summarized. At the end of the day, what is the recommendation for a PPD positive, HIV positive person in the United States or just around the world? What would you say would you do, I guess, is the bottom line.
So I guess I would use one of the 3-month regimens, either isoniazid and rifampicin or rifapentine and isoniazid. And again, one is a daily, one is a weekly, but I would use one of those two regimens. I think isoniazid is a good regimen if you think your patient will be adherent.
Yeah. And maybe weekly observed therapy might be a way to go, since it's 12 doses, if I remember right, 12 weeks. Mm-hmm. Yeah. Okay. Yeah. So that's a possibility. Switching over to Cryptococcus. What about cryptococcal antigen and follow-up? And I can contribute to this one. This goes back to my early days.
I was going to say I'll defer that to you, because I think that according to the Mike Sag that I've read about, following that is not useful. And I have to say, it makes one nervous if the cryptococcal antigen is going up. I'm not sure it should make you nervous if it is simply stable and going down, but tell us what you're...
Yeah, so this was a study back in the early 90s, and it was published by Bill Powderly as a lead author, where the study that we had originally done on treatment with amphotericin B, 5-FC versus fluconazole, where the 2-week lead-in with the ampho B and 5-FC kind of won the day. The serum antigen did not help. It did not predict relapse. It did not mean much of anything. So following a serum crypto antigen, it would either stay flat, sometimes go up, sometimes go down, but rarely ever went away. Now, the CSF crypto antigen is quite helpful, because but the problem is you have to monitor it over time. So in the study where we were doing frequent LPs, we would see it come down pretty universally with treatment, and if somebody appeared to relapse, it would go back up. But at the end of the day, the culture is the gold standard. So following cryptococcal antigen is not something we recommend very much for those reasons. Next question is about a short course. Sorry, it jumped on me. Any suggestion that patients with HIV are more likely to have severe COVID or higher mortality? That's, I guess, from Raj's study. Raj has talked about a lot of this, but do you have any sense of that right now?
Whether COVID is more severe in HIV?
Right.
I'm not aware of any data that that's the case. I'd be interested if you know of any, but I think there's been a lot of discussion about that.
Well, and Dr. Gandhi, Monica Gandhi, will be getting into that a little bit in terms of maybe what tenofovir might do. So that's a tease for our next section.
Well, that's obviously a hotly debated issue, and we've been through that with lopinavir. There's data about other.
Right.
There is discussion about other things, but the whole issue of immunosuppressed patients and whether, in fact, they have more severe COVID, I think in most instances is still an unresolved issue, with a few exceptions about people with specific immune defects.
Yeah, and I think most of us are working from the premise that there's not much difference. That may change with more data, but right now it appears that the outcomes on somebody on antiretroviral therapy who gets COVID, that the outcomes are quite similar to those non-HIV infected individuals. So we'll talk a little bit about that in the PrEP situation coming up. What about high-dose liposomal amphotericin B as a relevant option in place of the 2-week induction? Short course, high-dose liposomal A and B.
Yeah, I mean, there are trials in Africa with 1 week of liposomal amphotericin. Whether or not there's really any advantage in the United States of trying another regimen, I think is unclear, because 2 weeks is well tolerated. In most situations, there are the resources to give 2 weeks. So we have a lot of experience with that with 5FC. I think if you're in a situation, again, where you have trouble administering it, where you don't have 5FC, there may be reasons to look for other options. But I think it's hard to know how relevant that is to the U.S. Right.
Okay. If it's all right with the audience, I'll just call out the name of the person who's asking the question. Hopefully that's okay. So one of the Sarah Back was asking about drug-drug interactions with ARVs regarding the treatment of a positive PPD. You mentioned the rifampicin, and yeah.
Yeah, well, I mean, I think that in a way you have to look up each of these, because there are two problems. One is these drugs rifampin and rifampicin have a number of drug-drug interactions, but also a number of these regimens have only been studied in the setting of certain antiretrovirals. So, the approval is generally based on what populations are being studied. And again, if a regimen, for instance, has only been studied with efavirenz, it would be nice to know not just the drug-drug interactions, but to have some clinical experience. I think that is a limitation with the rifampicin as well as the rifampin-based regimens.
Right. And when in doubt, there's a University of Liverpool drug-drug interaction charts that you can go to. It's online. I use it all the time, and because I can't keep in my head all the drug-drug interactions. So I think when we're in clinic, just go to the University of Liverpool drug-drug interaction for HIV and hepatitis, and you can get that. Time is moving quickly. Let me just make a quick comment about crypto again and the 400 versus 800 maintenance. Back in the day, we didn't have antiretroviral therapy to speak of, and so all those early studies that showed it worked was in the absence of ARV therapy. We typically start that a little bit later for crypto than we do. It's not like PJP where we start immediately. But what I found with 800 milligrams is that there was a lot of nausea. I mean, a whole lot of nausea. So I don't know how much that's appearing in some of these studies, but that was one one concern. Sarah Beck had another question about that in terms of length of treatment for primary prophylaxis with fluconazole after an episode. So somebody had it, you have them on ARVs, they're on fluconazole sort of on an indefinite period. Henry, what are your stopping rules for when it's okay to stop the fluconazole?
One of the limitations we have is a lot of the studies were done before we had effective antiretrovirals. So again, the guidelines would say you have to be on at least 52 weeks of therapy. But I'm not sure that that's based, or I know that that's not based on data in the current era with effective antiretrovirals. So I think that would be the standard. But whether that's necessary, I don't know. I guess I'd bring that back to you, Mike, and say, How long do you treat it?
Usually I follow the CD4 count, and as it goes above 100, I typically wait while the viral load is suppressed, wait at least 6 months for that situation, and then it's pretty safe to stop. It's an art, not a science at this point, as you point out, but the OI guidelines has this laid out pretty well.
I was just going to say one of the problems with the antiretroviral guidelines is that, again, as I mentioned, most of these studies have not been repeated for obvious reasons in the last 15 years. So it's hard to know how many are relevant. It's hard to really believe that your CD4 count goes up and your viral load is down, presumably at the same time. You need to continue to suppress, but there just isn't data.
Right. Just real quickly from David Hardy, he's asking about not switching from Ampho-B and 5-FC. Is there any situation where you would continue that beyond just the 2-week time period?
Well, again, I think that gets into it being an art, not a science. I think there's some people, if you knew right away that your 2-week spinal fluid was positive, which almost never do you really know, some people would. Well, not some people. You should extend that past that. But in the absence of that, I think we've certainly seen patients here where patients are not doing well, however you want to define that, 2 weeks, so they get a longer course. But I don't know of any rules other than the fact that having a positive culture is an indication.
Right, and it gets convoluted because a lot of people won't repeat the LP to see the culture still positive, and it takes a week, and so now you're into week 3, and it's very difficult. So most people just at 2 weeks stop the Ampho-5-FC, switch over to fluconazole, and we're usually using 400. Quickly, there's some follow-up questions on the CD4 count. If it goes above 100, what if it drifts back down? If the viral load is suppressed, that's the key thing. A lot of people don't have it drift back down. If they do, it's kind of just a lab fluctuation. So I would say you monitor it carefully. If it's going between 105 and 95, I wouldn't necessarily call that. But usually as it's going up, it keeps going up. But the undetectable viral load is the key because the virus is the thing that's immunosuppressive, and that's really where the function of the immune system is disturbed, is mostly by the high volume of virus that's circulating and creates immunodeficiency. Well, thank you, Henry. That was great. We're going to move on to our prep panel.